And if you look, this is the brain response, the hemodynamic response for subsequently remembered versus forgotten words. Look at the time scale, though. It's very different to the millisecond time scale. So this is 10 seconds here. So highlighting the difference. Okay, so I'm trying not to talk too much about the emotion and adrenergic system, because some of you may have been at the charla I gave at the Complutense de Semana de Cerebro. So I didn't want to overlap with that, but just for those that weren't there, I'm very interested in the adrenaline system in the brain. So just like we have adrenaline going around in our bodies that's produced by the adrenal glands, we have a system of adrenaline in the brain, which is produced here in a nucleus called the locus ceruleus, which sends adrenaline to all parts of the brain, basically, as part of the pathway which is also in which we synthesize dopamine, noradrenaline, later adrenaline. So the reason I'm interested is in the 70s, studies in animals showed that the aversive or fear conditioning, which was I mentioned before, was like Pavlov and his dogs, except it's mainly done with rats and giving them electric shocks paired with a tone. That learning is dependent on adrenaline in the amygdala. So the local circuitry of this part of the brain called the amygdala, because you can block this learning by giving a drug called propranolol, which is a beta blocker, which you might have heard of because people take beta blockers for, say, exam stress, or if they're going to give public speaking and they don't like it. I think it's called Sumial in Madrid, Sumial in Spain. So it's quite a commonly used drugs for people that play musical instruments to keep their hands steady, things like that. So the fact that this learning process can be blocked by an adrenaline blocking drug, it also turns out that the ability for emotional memories to be stronger than neutral memories, because of course we remember our emotionally charged events, our frightening events in our lives much better than we do the neutral ones. That also is dependent on adrenaline released in the brain, and it seems to be the effect of the amygdala influencing the hippocampus via adrenaline. So as an example of this, if you show people this is a simple psychological task where you show lists of words. So these words are all semantically related. So these are all talking about groups. So gathering, meeting, people, conference, assembly, but have one that's emotionally charged, like massacre. What you see is that if you are in the placebo group, you have a much enhanced memory for the emotional word. So there are two types of unusual words in this paradigm. There's a perceptual oddball, basically to control for the fact that the emotional words are quite infrequent. So you have something else that's quite infrequent. And if you do in the placebo group here, if you compare, so these are percent recall relative to all other words in the list that aren't either perceptual or emotional, you see the strong enhancement of emotional memory. But if you've taken the beta blocking drug, this enhancement completely goes away. So what we did was the drug or the beta blocking drug was given, the beta blocking drug or placebo was given in the morning. They then had an encoding session, and later, after the drug had washed out of the system, we did a recognition session. So you see this big enhancement of memory for emotional words that is completely gone if you take this drug, beta blocker. And what we saw was that during encoding, you see this activity here. This is in the amygdala. So when you're in the placebo group, when you remember an emotional word versus when you forget one, you have this strong enhancement bilaterally in the amygdala. The important thing is that this effect is present with the interaction between group. So the effect is much stronger it's present in the placebo group, but not present in the propranolol group. So you can see that in the placebo group, when you remember an emotional word, you get this enhancement, which is bigger than the emotional word that's subsequently forgotten. But if you take propranolol, this effect goes away. So you can see that there's both a behavioral and a neurophysiological correlate of this memory enhancement for emotional items. So it's all well and good to be doing this research. It's very interesting, but how do you transfer it to patients? 'Cause you need to really be thinking this is something ultimately you want to benefit at least, some diseases. And one way in which we've used functional MRI to the patient's benefit is to try to predict post-surgical outcome in patients with medial temporal lobe epilepsy. So I mentioned this earlier on. So these are patients that have something called hippocampal sclerosis, which is probably caused when they're very young, when they have febrile convulsions in these patients. Drug treatment, frequently unsuccessful, and surgery seems like the best option. So if you remove the affected hippocampus, you actually get 60% of these patients to be seizure-free. Now, the problem people have, so the problem that the average neurologist will have referring these patients to surgery is that you run the risk, of course, that if you take out some of the hippocampus, you'll get memory deficits at the end, so that could be even worse. So how do you predict which patients are going to have memory deficits after they have their hippocampal resection, which won't? So because the current techniques that we have don't really work. So we did an imaging study in 16 patients. So these are all right-handed patients, and we're looking at left hippocampal sclerosis because in right-handed patients, the lateralization of verbal memory is on the left and visuospatial memory is on the right, more or less. And they had variable severity of this hippocampal sclerosis. You can see here how bad the hippocampus can get. I mean, it's really shriveled there, isn't it? And we did the following protocol. So before anything, they had a preoperative neuropsychology memory test. Then we did the functional MRI. Then they went to the operating theatre and had their left medial temporal lobe taken out. Then 3 months later, they had a repeat of their neuropsychology and memory testing. And we were looking for the difference in the pre versus post-operative memory testing. So the experimental paradigm we did inside the scanner, so in this part, so the neuropsychology memory testing was standard neuropsychology memory test. So we did an experimental paradigm in which they were shown a list of words and there was a 90-minute delay. List of words during scanning, then a 90-minute delay. They had a recognition test outside of scanning. So we also did volumetric studies looking at the looking at the structure of the brain. And what we see when we looked at the post-surgical memory change, so the if you just look at the preoperative verbal memory, the better the preoperative verbal memory, the worse the post-operative verbal memory changed. So the better they were at memory, the more they had memory impairment, which is a bit of a shame. But if you think that they had more to lose, just look at the correlation value here is of 0.5 in these patients. A slightly better predictor is the amount of hippocampal volume they had to begin with. So the bigger the hippocampus they had, the more their memory dropped. Again, they had more to lose. But what we did was we thought that maybe the way the patients that improve, patients that are able to cope with their hippocampus being taken out are the ones that have managed to change from the left to the right. So if they've had left hippocampal damage for a long time, there's a possibility there was plasticity, so that the right hippocampus took over the role of the verbal memory. And that's exactly what we saw. So this is the difference between left and right encoding-related activity. So this is left minus right encoding-related activity. So the patients that had less left-sided encoding activity and more right-sided, so these ones, were the ones that did better after surgery. And the correlation coefficient here is 0.8, so it's a lot better than using the standard neuropsychological testing. Of course, with all these clinical things, you need to replicate, and you need to do more and more patients just to make sure before you use this as a standard protocol. So we're still working on that.